All right, thank you, Carmen. So I'm going to use my time to kind of go over some of the same things that Carmen did, but then I'm going to apply a little bit more context of kind of how we used it for our, so kind of the what and the how of what we did. Talking about some more of the specific details within the scoping review, again, in reference to what we did, and then discuss some of our findings, and then also as well as the opportunities and challenges of a scoping review. Carmen, would you go to the next slide, please? So here, we talked about evidence-based practice earlier. I want to revisit this because it was very important when going into the scoping review. A couple things to remember about evidence-based practice is that we use the best external evidence. So this is not limiting us to specific study types, not like randomized trials, meta-analysis, it's everything. So we're taking all of that and using it to answer our research question. We're also using our stakeholders, so clinicians as consultants, all kinds of different people involved in the process, as well as using the patient's voice too. So it's a culmination of everything. And we're doing that in order to kind of identify gaps, all kinds of different gaps in our evidence or in care when it comes to the actual practice. So what we mean when we say that scoping review has greater breadth over a systematic review, it has to do with that fact that we're not restricting our evidence. So from there, we take all of that, we're going to condense that information into charts, we're going to trace patterns across maps, across the different study types, and use those to kind of tease out limitations. Kind of to preface a little bit before I go any further, I want to mention that this is my first time doing a scoping review, so it was a little daunting, but there's all kinds of different resources that I was able to use, a lot through Ohio State, specifically the OT capstone manual, and as well as other external resources to kind of help me understand some of the methodology of finding these studies, assessing them, and then generalizing them to more real world scenarios in practice. Next slide. So in these next coming slides, I'm going to detail the methodology of what we did in our scoping review, and then as well as highlight some of the work as well. So the necessary steps are as follows. One, we have to identify our area of focus for our research question. So here we want to come up with a testable and scientific question in the terms of the review. Two, develop the appropriate PCC. So remember when we're talking about scoping reviews, we're using a PCC here because we want more content and we want less exclusion than you would find in the systematic review. So here, population, concept, context. Three, operationally define. So telehealth in our case. So here we want to establish a little bit more specifics. What do we mean by what we ask? What does telehealth really mean to people? What does it mean to us? Four, establishing a research question and its clinical scope. So how are we building and phrasing our questions so that other people will understand what we are trying to accomplish? And then five, this will be the search query. So using our exclusion and inclusion criteria to begin our extraction protocols. There are more steps, but I kind of wanted to leave off there and kind of explain a little bit more in detail what we were able to find out of these steps. So in the next slide, we will take a look at that. So let's break down what we have covered so far. So for our population concept, our context, we found our population to be male or female adults with chronic disease or disability. Concept was remote assessment interventions and functionality outcomes. And then the context, delivering that care using telehealth or in-person visits to kind of create a kind of comparison between the two. For three, we define telehealth for our purpose. So here we have it as a delivery of healthcare services through telecommunication technologies to perform assessment or healthcare intervention. And then four, so our research question, one of the more important pieces of information here on this slide. So are telehealth remote assessment models sufficient in their effectiveness to properly perform assessments, as well as deliver health services to adults with chronic disease or disability? And then when compared to in-office or in-clinic assessments. And then from there, we took that research question, built our search query, and then we kind of went into data extraction. So on the next slide, I kind of break down step 5 a little bit more because there is a lot involved when it comes to creating a query. So to begin the query itself, it's usually common practice to start with coming up with your inclusion and your exclusion criteria. So I want to say that this was not our first go at building a query. I know it looks like it was pretty simple, but it wasn't. When we first came up with our query, it was pretty simple, and it generated about 1,000 results. And so that's a lot of things to siphon through, a lot of things to read. So we wanted to narrow it down. So using a lot of time, as well as kind of seeing how the query goes when you enter it, it's like a trial and error process, essentially. We were able to narrow it down eventually. And so the importance behind these queries is you're using these logic statements and, or, and not. And so your search results are entirely dependent on how you compose those phrases into a single statement. So kind of having an understanding of that logic is important. And then from there, it's just plug and chug mentality, seeing what keyword criteria are important for the results that you're looking for. So we took the following criteria and we used PubMed, which is a research database, and we built our query using their query builder. So you can see that in bold. Using that query, we were actually able to get 618 results, which is a lot more manageable when you compare it to the 1,000 to 2,000 that we originally had. So from there, we kind of took those 618 studies and went into our data extraction, our screenings, and all of that. So we will talk a little bit more about that in the next slide. So study selection. So as Carmen mentioned previously, we used Covidence. So again, this is a tool that we used for study review management. And the question that was asked earlier was in regard to how we use Covidence. Just a data extraction tool. There's no actual search that goes down with Covidence. It's kind of a way for you to organize, chart, and do some of the extraction to help with the review. So once we were able to kind of import everything into Covidence, that's when we started to really look at the titles, the abstracts, and then full text screenings for these studies. So the first part in the title and abstract screening, here we're identifying keywords, phrases, along with our inclusion and exclusion criteria to kind of verify that these studies are what we want to be looking at. Beyond that, once we've kind of filtered through that, taken out the studies that don't belong, we go into our full text screening. So once you kind of reach this point, you've narrowed it down to a lot or a little less studies compared to what you had at the beginning. Here we had 26 studies, and we went and read through everything a little bit more critically and a little bit more in depth. So here we were looking at the study's relevancy to our research question. What is it telling us? You know, what kind of angle is it taking to answer our research question? So from there, then we go into step 7. So creating, organizing, and presenting data. So this is where we start to extract different pieces of evidence using these 4 tools listed below. So we start to analyze them, and we analyze them specifically using somatic analysis in the case of a scoping review. So I will touch on each of these 4 components in the next coming slides. So let's start with thematic analysis. I'm going to go to the next slide, please. Thank you. So thematic analysis, this is going to be one of the building blocks for pretty much which everything will come to fruition from. So we are using it because we can quantitative data. So here, what else, including numbers, is being told to us? And, you know, it ties into the fact that we have a lot more breadth. You know, we're not excluding all those other types of studies. We're looking at everything. Every piece of evidence matters, including the qualitative data. So then we use that, and we can start labeling patterns across both forms of data sets, you know, quantitative, qualitative. Then we organize them under umbrella terms, you know, effectively trying to expand on them, adding clarity and a little bit more content volume to those. And then it allows us to rephrase that information. So using those themes, we can present them in more relatable terms. This helps the author and the reader interpret and apply more meaning to the data that's being pulled out from the scoping review. So ultimately, those 4 things previously help you look at the bigger picture. So what's the message? What are we able to take home from what we gathered? What are the gaps in evidence, essentially? And so below, I kind of listed out some of the themes that we were able to tease out from our own review. And I will definitely go into these in a little bit more detail later on, but I just kind of wanted to present them here to you so you could see kind of what that looks like. So in the next slide, I want to talk about Prisma. So this is a tool that we used. It's a visual tool that allows us to track kind of the flow of information as we go through our review. So you can see along the different steps where studies were removed and where studies were kept in for our review, as well as reasons why for exclusion. So this is, again, a useful tool for keeping record, as well as better reporting on information that we find throughout the study. I do want to make a note that a Prisma does not serve as a means of quality assessment. It's just a tool to visualize data flow and improve reporting. So it means in no way looking at these studies and determining their levels of evidence, whether they fit or not in terms of the content within them. This is just to kind of show where we took out studies and where we kept studies. Well, highlight on this slide, and in particular, our specific Prisma diagram is at the bottom. If you see, there's one study handpicked for inclusion. I want to make note of that because typically you don't see that. We kind of went back through some of our studies that we excluded because we wanted to make sure that they were excluded for the reasons. So you can see below the reasons for exclusion. And so this one study was taken out because it didn't fit in our date range, but kind of going back, we realized it fit in with a lot of the themes from pretty much all of the other studies that we had looked at. And so because it fell under all of that, we figured it was quite important. So we kind of reintroduced that back to our review. So once all of that was said and done, we've created the Prisma. That's kind of where we begin to start working on our concept map. So in the next slide, I'm going to talk about what we call the Oxford levels of evidence. So this comes from the Center for Evidence-Based Medicine. This is a tool that people use to kind of help organize and classify their studies based upon what is inside of those papers. So each level has different characteristics that are dependent on what is presented within the paper. And so that different information can be used to reinforce different ideas within our review. And so by color coordinating them, it allows the reader as well as the author to kind of get a better understanding of what the studies actually are and what kind of evidence we're using to support our ideas, our themes and claims, and et cetera. So once we've classified these studies, we can use all of them to start mapping out our themes. So in the next slide, you will see our concept map. So here is our concept map. I'm not entirely sure if it's very clear for all of you to see. So I will kind of talk a little bit more about that and themes within it on the next slide, but I want to stay here just to kind of show you what the concept map does. It allows us to illustrate the different themes, the potential gaps in evidence, and then kind of convey the amount and strength of evidence that we have to support those themes. So in reference to the actual map itself, you can see there in navy blue on the middle our research questions. So this encompasses our PCC. It's a little shortened version of it just for the sake of fitting things in. And then stemming from that, you're going to see three darker colored text boxes. Those are going to be the three major themes that we were able to identify. So telehealth, service delivery, and assistive technology. Each of those comprised of their own sub-themes as well as their respective studies. So in a way, the mapping kind of worked its way backwards. So you kind of begin with themes, more specific nitty-gritty stuff coming from those studies, but we need to establish some way to generalize it. So try to unify them under a broader context. So that's kind of what those three major themes are. So like I said earlier, we're going to go to the next slide and take a look at some of the more like listed out themes, so it's a little bit easier to see. So using the slide, taking a look at the themes, I want to talk about the three major themes first. So the first one we have So I kind of want to explain and expand what these mean. So telehealth, this theme kind of encompassed a lot of concepts that I would say are the cogs to telehealth. So what is necessary for telehealth to work? So under that, we have frameworks, models, policy. So what is telehealth or how it works? We have barriers, the limitations to telehealth. In some cases, that can be policy. Sometimes it can be population perception. Who is involved? Those are going to be our stakeholders. Or to even ask who isn't involved or as involved. Those are going to be your underserved populations. And then we have other details such as cost benefit analyses, as well as reimbursement. Moving on to the next major thing is service delivery. How do we implement telehealth? What forms does it take on? How do we measure its service and its impact? So assessment and interventions, those are going to be the methods and tools that we use to deliver that care. Then we have telerehabilitation, home accessibility mods. Those are going to be a little bit more specific use cases. So those are types of interventions. But I kind of wanted to elaborate a little bit more on those because there was a lot of detail from some studies about those specific cases. And then last, we have the follow-up scores or assessing delivery. So how do we measure what we are doing? As a lot of you are familiar with FMA, we have Quest. Those are ways for us to assess our delivery protocols. And then we have our assistive technology. This one could have been classified as a specific use case, but there was a lot of breadth, a lot of material under assistive technology that it warranted its own category and its own theme, especially because we're trying to look at assistive technology in telehealth. So that is a separate thing. So this includes a lot of different forms of assistive technology that are used within telehealth, wheelchair mobility assessments, AACs. Sometimes this was unique to us, vision assistive equipment, something that I have not been familiar with before. And then we also have another theme called uptake and use of assistive technology. What kind of things play into people wanting to use these things? So from there, we have our themes, and then we begin to establish our evidence table. So in the next slide, I want to take some time to talk about our evidence table. So this right here is a small sample of the more grandiose evidence table that we made. I want to focus on the top row and what's in red. So these are different analytical components that we use to break down the different pieces of information within a study. This is where the data extraction becomes really important. Carmen talked about the Cochrane method that's used in systematic. Well, we kind of came up with some of our own ways to do that. And that was this table right here. So you have your author, you have the years of the study in which it was published. You have themes where we put our themes that we kind of defined. Study aim and objective. What is the goal or purpose of this study? Design, method, rating participants. These will contain information pertaining to the study, how it was done, or reasons for why the paper was written. So like in the case of another review, it's all dependent on what type of evidence or what type of study it is. Intervention, outcome. So these are going to present tools, techniques, actions that were used to accomplish the study. Results will obviously kind of demonstrate those findings within the study, but not least is interpretation. So this one right here is probably and arguably one of the more important sections of the evidence table from the standpoint of composing the review itself. So in this section, we take the results of our study and other relevant information to kind of formulate it in a way we can relate it to our population, concept, context, and ultimately our read. So then writing the review comes next. Once you finish the evidence table, you start talking about actually composing the review. So like most reviews, like most studies, most published papers, you're going to find the same kind of structure. Abstract, introductions, methods, results, discussion, and conclusion. I don't want to dwell too much time on this. Most of us kind of understand how that works, but it's very similar to like most things you will read in the scientific community in regards to literature. So next I want to talk about the conclusion of what we were able to kind of get from this review. This is really important slide. So some of the things we discovered first was that remote treatment can be quite as effective, if not more effective sometimes in person. And this isn't due in part to a few things. Personalized healthcare, This is an idea that there's no one-size-fits-all type of treatment for individuals seeking healthcare services. Two, understanding barriers. So these barriers are in regard to adopting the use of remote services, so telehealth or assistive technology. So being able to address complexity that is in, complexity of people by acknowledging different user concerns. And that includes patient, clinician concerns, any kind of stakeholder. And so some of those concerns are based around the effectiveness, accessibility, reliability, functionality, timeliness, reassessment ability to design. How does it all work? Is it working effectively? And so we kind of measure that effectiveness through satisfaction. So it's a big part of how we are able to determine the inclinations of people to use or their future use of telehealth and these services. Next, we have our increase in demand of services and areas for improvement. So we know that there's going to be an ever steadily increasing demand for telehealth and healthcare services. And we revealed gaps in care that would suggest needs for improvement in the 4 areas listed below. So infrastructure, what are we using to build the models and the frameworks, the procedures being used for interventions, all of that. Second is access, probably one of the more important things. So how readily available is this healthcare to people? How are we using telehealth to make it more accessible? What about underserved populations or the benefits or insurance policies that go in play to giving more access to these health services? We also have quality. So what are we doing to ensure that the standards we see for in-person visits are being maintained for remote as well? Is it still efficacious? Next, we have privacy. This can double back to infrastructure too, making sure that these networks, the hardware being involved is good and secure. PHI, or what steps are we taking to ensure that we are maintaining PHI while doing these remote sessions? Lastly, we found a large consensus around these last couple of ideas. Collaborate and share ideas more effectively, we can unify our efforts to create more robust care, strengthening the elements that go into it. So sharing those ideas, those concerns, as well as research can help us organize, a vision together to solidify this. Creating unified models and frameworks allows us to more easily implement telehealth through different communities, making it more replicable, essentially. And then finally, we have standardization of measures. This helps with reimbursement benefits, changes to policy that can better reflect the capability of telehealth. It just makes everything a lot easier. Again, more of that replicability in the process. So kind of understanding all this helped us mitigate a lot of the shortcomings of telehealth and help promote the program's success as seen throughout our scoping review. And the next few slides, I want to talk about some of the challenges and opportunities that are presented when conducting a scoping review. So challenges. Again, I want to say that this was my first time doing a scoping review. So a lot of this was very new to me. It was a very daunting first. So when you're doing a scoping review, it seems like a lot is going on. You're going through all these studies. 618 studies seems like a lot at first. And building that query took some time as well. So it's pretty labor intensive. Again, establishing those queries, filtering. You're doing title, abstract, and then eventually a full text screening. And you're doing this over and over again. It's that iterative nature of the review. And so it can become a little monotonous. And narrowing down all the studies and going reading through them takes time. And that actually took the longest time of the review. So that was hard. And then composing the review itself was a challenge. Now that you've collected your evidence, you've organized it, you visualized it using the concept map and all of those tools, how do you present that information in a clear and concise written manner so that all the people that you've consulted with, people who are interested in the field, how are they going to be able to understand the information that you've collected? So specifically writing the discussion, relating it to real world context. How do you convey those ideas? So if your reader is unable to, follow those ideas in the not going to be convincing enough, with your claims and your call to actions. So I spent a lot of time playing around with the discussion. So that's enough of the challenges. I think there's a lot more time to talk about the opportunities of a scoping review. And I think these are a little bit more important than focusing on the challenges. So here, I'll start with mentioning the overall breadth of a scoping review. When I hear the term scoping review, imagine it like the periscope on a submarine. It's composed of many mirrors, or in the case of the review, it's actual studies, and you're using all of those to create different angles to approach your question. What would typically be hard to understand, you now have all these angles to approach the question, so you can understand a little bit more of what you're getting at, and eventually delve into more specifics. Typically, you'll use the scoping review to go to systematic reviews. Explore more specific using the rigidity of a systematic review. Anyway, we then use that. So let's move on to content validity then. So we've already covered the breadth. We understand what that is. So having a lot of resources, literature, studies, stakeholders, clinicians, all those consulting materials, you can more effectively improve your practice and knowledge using that content. It allows you to better investigate the validity, the reliability of the information at hand, and applying it in real world scenarios. So as I said earlier, scoping review is kind of like a bigger part of an end goal, continuing an investigation to the development of a universal, replicable clinical model technology, and how we can use that to improve healthcare. So I'll kind of wrap it up there with my section, and I'll hand it back over to Carmen.